Hello everyone. In this lecture, I am going to discuss about the physiological changes during pregnancy. So in that we'll discuss in a brief that what all systemic changes the woman may have, because there is additional requirement for the nutrient as well, because there is a fetus in a utero. Yes. So there is additional requirement for the nutrient and for the exchange of waste in between the mother and the fetus. So to fulfill all this requirement, there are variety of changes that appear in a woman's body. So let's talk about the hematological changes first. So we know that the blood is a liquid tissue which is mainly composed of plasma and the blood constituent RBC, WBC, clotting factors, plasma protein and all. So what happened during pregnancy? The women remain in a hemodilution state. Why? Because what happened, as the demand for the mother and the fetus is rising more with subsequent weeks of pregnancy, the blood volume is also increasing. But in blood volume, the plasma part is increasing more in comparison to the RBC mass. Okay, so like if the plasma portion is increasing 40 to 50%, in comparison to that, the RBC mass is increasing only 20 and 30%. So because of this disproportionate increase in the plasma volume and the blood constituent level, the women remain in a hemodilution state. Yes. So this blood volume start increasing from 5th week of gestation and it reaches at peak around 32 week of gestation. But this hemodilution is very beneficial for a woman, because at the time of delivery, when the blood losses appear, this loss is usually limited because the blood is diluted. If it remain viscous, if it is remain thick, then the RBC will be lost more. But it is not happening like that. Because of this hemodilution, the loss of RBC is limited. So this hemodilution prevents the adverse effect of blood loss in a woman. And a very important thing is that this hemodiluted blood is very important for the exchange of nutrient and gas in between the mother and the fetus, because as the blood is more diluted, it allows more exchange of nutrient and waste and the gas in between the fetus and mother. If it become thick, then the exchange become very minimal. And along with that, at term when the woman lies in a supine position, it also prevents the adverse effect of this position, because when the woman lie in supine position, what happened? This gravid uterus usually compresses the inferior vena cava, and that can cause hypotension in a woman. So with this diluted blood, what happened? The blood flows very freely. If it remain viscous, the blood will be very thick to move. Okay, so this diluted blood is very beneficial in supine position of the woman also near term. Okay, that prevent the adverse effect of supine hypotension in a woman near term. Okay, and along with that, if we talk about the WBCs, these all counts increases during pregnancy, and the immunity of a woman usually shifted from T1 to T2. That is, this is shifted from cell mediated immune response to antibody mediated immune response, because the mother do not want that her fetus is usually rejected by this immunity response. So the cell mediated response is shifted toward the antibody or humoral immunity. Okay. Now if we talk about the coagulation, then the woman remains in a hypercoagulable state during pregnancy, because at the time of delivery, as the placenta gets separated, there is a blood loss, because the blood vessels are torn and the bleeding may appear. So at that time, this hypercoagulable state prevents the excess loss of blood. Okay, so the woman remain in a hypercoagulable state where the fibrinogen level is rising more, the blood clotting factors are rising more, that prevent the adverse effect of excess blood loss at the time of delivery. Okay, but the factor 11 and 13 usually decreases. Otherwise the other clotting factor usually rises during pregnancy. The women remain in a hypervolemia state during pregnancy, because here the water retention is more near term, and it is around 6.5 liter in whole throughout pregnancy, and out of 6.5, the 3.5 liter of water is in fetus, in placenta, in amniotic fluid, and remaining water is retained in the body tissue of the mother, in the blood, in the extracellular tissues. Okay, so this water retention is usually the effect of estrogen, which act upon the main organ which is responsible for this water retention is the kidney. So when the estrogen act upon the kidney, it stimulates the RAAS system, that is renin angiotensin aldosterone system. So when it gets activated, it absorbs more sodium and water. Yes, it absorbing more sodium and water, but what happened? The sodium is absorbing less in comparison to the water. So here, with this activation of RAAS system, more water is retaining, more water is absorbing. But although the RAAS system is activated, the blood pressure is not rising in women, because there is the effect of progesterone which make the smooth muscles to be relaxed, and that may lead into the relaxation of the vessels, and that may cause the vasodilation, and the flow is very slow. Okay, so the water retention is the effect of the kidney, which under the response of estrogen absorbs more water and sodium. And along with that, what happened with this diluted blood, the plasma osmolality usually decreases in women. So once this plasma osmolality decreases, that decreases the osmotic threshold for thirst. Okay, so there is a particular level where the woman, we all usually feels thirst, but that particular level usually decreases because of this hemodilution. So when the plasma osmotic threshold decreases because of this hemodilution, that causes excess thirst in a woman. Okay, and that may cause the excess intake of water, and ultimately it increases the water amount in body. Okay, so along with this hypervolemic state, the woman gains 11 to 12 kg of weight during pregnancy in a singleton near term. So this whole weight is because of the retention of water in blood, in extracellular fluid, the weight of breast as well as the uterus, the body tissue, as well as the weight of the fetus, placenta, amniotic fluid. This all contribute in the gaining the weight of a woman. Okay, so in a singleton pregnancy, a woman usually gain 11 to 12 kg weight. Now next comes the cardiovascular changes. What all changes we can observe in the heart? So what happens as the pregnancy advances, the growing uterus move up and up. This shift the diaphragm slightly upward, and because of this diaphragm goes up, what happened? The heart slightly pushed upward and slightly outward. So because of this displacement, what happened? The apical pulse, which we are feeling in the fifth intercostal space in non-pregnant state, usually shifted upward, and we can observe this beat at the fourth intercostal space. Okay, but it is not in the midline of the mid-clavicular line, it is just outward, that is 2.5 centimeter away from this mid-clavicular line. So the heart is slightly pushed upward, and because of that we can felt the apical pulse just outward and slightly up. Okay, the important thing is that as the metabolic need is more, the oxygen demand is more, the nutrient demand is more, what happened? The cardiac output usually increases, that is the amount of blood which is ejected from the ventricle is more, because blood volume is also increasing. Okay, so what is the cardiac output? That is the stroke volume multiplied with the heart rate. So here the heart rate is also increasing in women, and the stroke volume, that is the blood which is ejected by the ventricle, that is the left ventricle, is also more. Okay, because the blood volume is also increasing. So as the blood volume is increasing more, as the demand is more, that's why the cardiac output also goes up. So it start increasing from 5th to 6th week of pregnancy, and it reaches at peak at 32 week of gestation. Okay, so it is rising 40 to 50% in comparison to the non-pregnant state. But if we compare the cardiac output during pregnancy, at the time of labor and after delivery, then we can observe that at the time of labor it is more. The cardiac output is more in comparison to pregnancy. Because what happened at the time of labor, once the uterus become contract, the blood which lies in these uterine vessel which supply in this uteroplacental bed, that usually shifted in the maternal circulation, and that add in extra amount of blood. So that's why the cardiac output is also increasing at the time of labor. And at the time of delivery also the same things happen, that once the placenta is going to be delivered out, what happened, the uterus is contracting more and more. So once the uterus is contracted more, the blood which lies in this uteroplacental bed again goes in this maternal circulation, and that contribute in extra amount of blood in the cardiac output. So after the delivery also, the blood which remain in this uteroplacental blood which completely shifted in the maternal circulation increases the cardiac output. Okay, so although the cardiac output is usually increasing, but here the SVR, systemic vascular resistance, is usually decreases. Why it is decreasing? Because the effect of progesterone combinedly with the estrogen and the nitric oxide, this all combinedly causes the vasodilation effect on the blood vessels. So progesterone usually dilate because the effect of progesterone is smooth muscle relaxant. So as the smooth muscle relaxes, the vessels become dilated and the flow become more, the resistance become low. So that's why the systemic vascular resistance is decreases, although the cardiac output is more. Okay. With this, the blood pressure, because the resistance is low, the blood pressure also decreases. So especially the diastolic blood pressure decreases here. Okay, but near term what happened, there is a chances of supine hypotension syndrome, because near term what happened, as the gravid uterus grow more and more, that creates a pressure on the inferior vena cava if the woman lies in supine position. So that's why it is called supine hypotension syndrome. So we just ask a woman to avoid this position and just remain in a left lateral position to avoid this syndrome, because if the woman lies in this supine position, the pressure exerted by this gravid uterus compresses the inferior vena cava, and that's why the flow will be curtailed or it will be diminished toward the heart, and that may lead into the hypotension if the collateral circulation doesn't open. That may be possible in very least condition, but to avoid this condition we can ask that just remain in lateral position, especially in left lateral, because in sitting as well as in supine position the cardiac output is slightly low, but in comparison to the lateral position it remain high, because the vein which lies underneath this gravid uterus is not compresses in this lateral position. So that's why the flow will be adequate and that remain the cardiac output high. Okay, so there may be a chance of supine hypotension syndrome if the woman remain in supine position near term. Okay, so these are the changes that we can observe in the cardiac system. And if we talk about the respiratory system, what happened, as I told you before, with the growing uterus, the gravid uterus just displaces the diaphragm upward around 4 cm, and as the diaphragm goes up, what happened, the residual capacity decreases, because this thoracic cage is now not that much exceeding downward because of this gravid uterus. So during pregnancy we know that there is a additional requirement of oxygen for the mother as well as the fetus, because the fetus cannot be exchanged its gas its own. Okay, it completely depends on mother. So to meet the additional requirement for this oxygen for the fetus and the mother needs additional oxygen. So to fulfill this additional requirement, what happened, the mother breathes more. Okay, so there is a hyperventilation. As the mother breathes more, there is a deep inhalation. Because of that, there is more oxygen which flows, and that fulfill the additional requirement for both of them. So what happened during pregnancy, as the fetus is exchanging its carbon dioxide in the blood of the woman, and the more oxygen is transferring from mother to the fetus, the more carbon dioxide remain in the blood. So to clear out this carbon dioxide CO2 in the arterial blood, what happened? The progesterone is usually sensitizes and it triggered the respiratory center, and once it become triggered by this progesterone effect, what happened? The mother breathes more. Okay, so there is a hyperventilation, deep breath is there. So because of this deep breathing, the tidal volume is usually increases. So there is more amount of air which could be inhaled and that is exhaled by a woman. So that's why the tidal volume usually during pregnancy increases to clear out more carbon dioxide from the mother's arterial system and to inhale more oxygen to fulfill the demand for both of them. So the tidal volume is usually increases, but the residual capacity usually decreases because of this shifting of diaphragm upward. So because of this excess clearance of this carbon dioxide from the blood of mother, the woman remain in a respiratory alkalosis during pregnancy because the arterial carbon dioxide pressure, partial pressure remain low, and comparatively the partial pressure of oxygen is high because mother is usually taking deep breaths to fulfill the demand of both of them. The chest circumference is usually rising because of the upward displacement of this diaphragm. Okay, so it is rising 5 to centimeter more, that the chest circumference, and along with that the subcostal angle, which is usually 68 degree, it is also more, that is 103 degree it is rising because of this increase in chest circumference. Okay, so the woman feels shortness of breath or dyspnea near term because of the low partial pressure of carbon dioxide in the arterial blood. Yes, so sometimes to compensate this respiratory alkalosis, the kidney usually remove or excrete excess bicarbonate to compensate this respiratory alkalosis. Now next we talk about the urinary system, and in that this system plays very important role because here the organ, that is the kidney, plays very important role in absorption of sodium and water. So here the kidneys are enlarging slightly, as well as the ureter is also dilating under the effect of progesterone, which dilate because of the smooth muscle relaxant effect of this progesterone. And along with that, the renal blood flow is also increasing because the blood volume is rising and the progesterone causes vasodilation. So blood flow is more, renal blood flow is more, and more flow is there, then the filtration will be more. So GFR rate is also increasing. Okay, so as the filtration is more uric acid, creatinine, urea, this all are excreting more in amount. Okay, so the woman may have frequency of micturition with this effect, but usually during first trimester it is more with this increase in blood flow, as well as the change in osmolarity of the plasma, because the woman with this decrease in plasma osmolarity, woman feels more thirst and she drinks more water and she excretes more. Okay, but it subsides in second trimester, but later on in third trimester, when the blood flow is more, the blood volume is more at a peak where the flow is more, as well as with this gravid uterus, when the presenting part just engages, it creates pressure on the bladder again, and that may lead into the incomplete filling of the bladder, and that may cause frequent urgency of voiding again. Okay, so in third trimester this problem usually arises again, and the ureter remain dilated. The right side of the ureter usually compressed by the dextro, right side rotated uterus near term. So that may cause stasis also. Okay, now next we talk about the GI system, gastrointestinal system, where again the effect of progesterone causes the relaxation of lower esophageal sphincter, that is the cardiac sphincter, as well as it decreases the GI motility, the motility of the intestine, the motility of gut. So the women usually have constipation in this period because the motility, the peristaltic action is decreases. But whereas in one advantage is there, that once the motility is decreases, it allows more time for the intestine to absorb more nutrient. Okay, but the woman may have constipation, and with the relaxation of these cardiac sphincter, the woman may have regurgitation of the gastric content, and that may cause heartburn, the burning sensation in the esophageal region. Okay, she may have more nausea and vomiting, as well as the mucosa of the gums become more hyperemic with the effect of these hormone, and even though they may bleed also. Okay, next we talk about the metabolic changes. As the metabolic demand for the mother and the fetus is more, the basal metabolic rate is also rises around 30%. So the protein is actively transported through the placenta in form of amino acid. So there is a positive nitrogenous balance throughout pregnancy. The glucose is also required for the mother as well as the fetus. So this glucose is also transferring through this placenta. So when it is transferring more, the women usually remain hypoglycemic during morning time. So it may cause fasting hypoglycemia in women, and there is an additional deposition of fat pad over the abdomen, over the breast, back, thighs. So that deposited extra fat or lipid in a woman, so that could be utilized by the mother as well as the fetus. Okay, and if we talk about the iron, then there is an additional requirement throughout pregnancy around 1000 milligram. So the demand is more during second trimester of pregnancy, where it is required 6 to 7 milligram daily, because as the RBC counts more, the more hemoglobin will be bound with this RBC molecule, and more oxygen will be carries toward the fetus and to the mother also. And along with that, the calcium is also required around 1 to 1.5 gram, and this is required because the fetus need to build their skeletal. So the skeletal could be built by this calcium, so it is absorbed more from the intestine. Yes, so for that the vitamin D3 production is usually rises, because it is very essential for the absorption of calcium from gut. Okay, so more vitamin D3 is increasing with the effect of these placental hormone, and that absorb more calcium from the intestine. Okay, so I covered in brief all the systemic changes that appears during pregnancy. Thank you.